Right, next up is respiratory system examination. Never forget to greet your patient. So you greet, create rapport, introduce yourself, and ask for permission, all right? So good morning, Mr. Desmond.
Good morning, sir.
All right. My name is Dr. Kachi. I'm a junior doctor in the team. I would like to look at you. I would like to look at you for a few minutes. Can I go ahead, please? Thank you very much. Right. Can you put your hands beside you? All right. Thank you very much. My patient is fully exposed. The chest is fully exposed. All right. So, like every other examination, we go through the protocol of IPPA: inspect, palpate, percuss, and auscultate. All right. So we inspect. So we inspect the chest wall, the anterior chest wall, at 2 levels. So we look at the chest wall over the chest. All right. We stoop so low, so that our eyes are the same level at the chest. Okay. So we go to the foot of the bed also, and also stoop to check for symmetry. Okay. So if there's any obvious symmetry, you could pick that up. All right. Even though you can see from this point that there's no asymmetry between the hemithoraxes, you must be seen to demonstrate what you would do in a standard clinical setting. All right. So that's inspection. Next up is the respiratory rate, which is also part of the inspection. All right. As a rule of thumb, you must be seen to distract your patient while you're trying to count the respiratory rate. Okay. So I'm going to ask my patient, can you give me your hand, sir? Thank you. All right. I place my hand on the patient's, over the patient's radial pulse, and act as if I'm counting the patient's pulse rate, and look at my watch while I'm counting the patient's respiratory rate. Okay. So, because if I don't distract my patient while taking the respiratory rate, the patient might begin to hyperventilate and the respiratory rate will be higher than normal. So I'm distracting the patient with my right hand, and I'm with my other hand checking my wristwatch while looking at the anterior chest wall, counting the respiratory rate. Okay. So after doing that, because it is a very short exam, you're not expected to count for 1 minute. So maybe 15 to 30 seconds will be just fine to just show your examiner that this is what you will do when you're counting for respiratory rate. Okay. Next up, we want to palpate. All right. So in palpating, the first thing we'll do is to check for tracheal centrality. All right. So while checking for tracheal centrality, we use 3 of our fingers. All right. The index finger, the ring finger, and the middle finger. All right. So the index finger, the ring finger, and the middle finger we use while checking for tracheal centrality. We use our ring finger, yeah, and index finger and ring finger, place them on the medial aspect of the clavicle, while we use the middle finger to run down and check for the centrality of the trachea. You must be seen doing this. It is showmanship. You must demonstrate to your examiner what you are doing. So my index and ring finger on the medial aspect of the clavicle, while I use my middle finger to run down. Okay. And please try and run down the tracheal length more than once. While running down the tracheal length once, you can actually find out if the trachea is central or not. But while you're doing it multiple times, it's actually showmanship. You're demonstrating to the examiner that this is what you will do. Okay. So when you run down the tracheal length, you should be seen to look at the distances between your middle finger and each of your other fingers to make sure that the distances between the fingers are equal on both sides. Okay. So that your trachea is central. In that case, if it's deviated, you must state the side to which it is deviated. All right. So next up is chest expansion and also percussion and expansion. Okay. And while examining the chest, from the examinations forward, we examine the chest in 3 zones, the 3 long zones: upper, middle, and lower. Okay. So everything you're going to do from here is going to be upper, middle, and lower. All right. So chest expansion. We'll grip the chest wall with our fingers while the 2 thumbs will be close to the midline. All right. As much as possible, let your thumbs be close to each other as possible. Okay. So you ask the patient, Mr. Desmond, please, can you breathe in and out? Okay. Out, in, out. All right. So that's the upper the upper lung zone. Remember, the landmark for dividing the lung zone, the upper lung zone is above the nipple. Just below the nipple, we'll examine for the lower lung zone. Then we examine for the middle lung zone. Then for the lower lung zone, we examine it by the sides. This is because there's hepatic dullness. The liver extends into the thoracic cavity on the right, while the heart cause some form of dullness on the left. So while examining it for the lungs on this side, for the lower aspect of the lungs, we move towards the side, okay? So above the nipple, just below the nipple, and to the side. So that's upper, middle, and lower lung zones, okay? So upper. So please, can you breathe in, out, in, out. All right, so we'll go to the middle. Breathe in, out, in, out. Okay. Breathe in, out, in, out. All right. So next up, we'll do the tactile vocal fremiters. Okay. So we ask the patient to place the ulnar border of our palm over the lung zones, the respective lung zones, the upper, middle, and lower, and ask the patient to repeat a word that will resonate, okay, while examining. So, Mr. Desmond, please, can you say 99?
99.
Okay. 99.
99.
Okay. 99.
99.
All right. 99.
99.
Now, for the lower lung zones, you move towards the side, okay? 99.
99.
99.
99.
Okay. Some teachings will say that you examine over each intercostal space or over each rib, but this will not be feasible in your examination because your examination just lasts for 3 minutes, okay? So we'll take the examinations in the 3 lung zones, which is also a standard teaching, all right? So while doing that, remember to compare each side. So upper with upper, middle with middle, lower with lower. So we don't take examination from one side then before moving to the other side. It is important to remember this, okay? So after that, we percuss. This is palpation done. We want to percuss, okay? And percussion is also over the 3 lung zones, all right? So we percuss. Remember, your wrist, the movement for percussion is at the wrists, not at the elbow, at the wrists, at the wrists. Always remember that. It is part of the technique, okay? Okay, so always remember the movement is at the wrist and percuss over the 3 lung zones. Comparing upper, middle, middle, lower, lower is very important. So next up, we want to auscultate. First of all, we must always remember how to place our stethoscope. Okay, the position of the stethoscope must be in line with the position of the auditory canal. So the stethoscope must be facing forwards. Okay, inwards and forwards. So this is how your stethoscope should be. Wow, it goes into your ears. Then you must be seen to check if the stethoscope is on, because some stethoscopes have valves that can be turned off. So you just demonstrate it by striking the diaphragm once or twice, okay? So once you're sure, you place the diaphragm of the stethoscope over the lung zone you want to examine and ask the patient to breathe in and out, okay? All right. So Mr. Desmond, so breathe in, out, in, out, okay, in, out, 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 in, out. in, out, in, out. All right. So that's the end of auscultation. Next up, we'll ask the patient to sit up and we'll do examination on the back of the patient. Okay. So Mr. Desmond, please can you sit up? Okay. So while examining the back of the patient, always remember to note where the anatomical landmark of the scapula is, the scapulae on both sides. Okay. So what it means is that we must always examine our patient between the scapula on that side and the spinal cord, the spinal column. Okay. So remember that we'll do our palpation, our percussion, and our auscultation at this level, the level between the scapula and the spinal column. The level between scapula and the spinal column is narrow at this point, but it spreads out at this area, the triangle of auscultation. Okay. So when we palpate, we percuss, then we auscultate at this level. It's important to note that. Okay. So palpate. All right. Say 99.
99.
99.
99.
99.
99.
99.
99.
99.
99.
99.
99.
Okay, so that's for tactile fremitus. All right, next is percussion. All right. Okay, so that's percussion. Next is auscultation. Remember how we put on our stethoscope, facing forwards, breathing, out, in, out, in, out, breathing, out, breathing, out, breathing, out, breathing, out. All right. Thank you very much, Mr. Desmond.